Hi guys, welcome back to another episode of OSCE Talk. Today we're going to be going through anemia. In real life clinical practices, this will be one of the most common presentations that you'll see. You'll often see people who are feeling tired all the time, and the causes are normally multifactorial, but today we're just going to be specifically focusing on anemia and what would be expected of you as a junior medical student taking an anemia history. So just starting off, what is anemia? Well, it's defined as a low concentration of hemoglobin in the blood. Hemoglobin is the oxygen carrying protein in the red blood cells. So for men, this is normally hemoglobin below 135, or in women, it'll be 115 grams per litre. And it's not actually a disease in itself, but it is a sign that something else is going on in the body. Hemoglobin is also, it's a molecule that binds to oxygen in the lungs and delivers it around the body, and it's built using iron. So we'll see that iron deficiency anemia is one of the most common problems, and that's what we'll try and look for in our history. But it can be caused by other things, such as people with chronic diseases or people with B12 or folate deficiencies, or from acute blood loss or chronic blood loss and things like cancer.
Yes, so you'll often hear anemia categorized based on the mean cell volume, and that just tells you actually how big the red blood cells are. So the three main classifications there would be microcytic, normocytic, and macrocytic anemia. Microcytic just meaning smaller cells, that's an MCV under 80, normocytic going from about 80 to 100, and then macrocytic, those bigger cells being over 100. And this just helps us sort of pinpoint down the possible causes. So I think it's really important just to think of what are the most common causes. So the most common cause of microcytic anemia is going to be iron deficiency anemia. That'll be things like due to poor intake of iron, or that might be due to loss of blood somewhere, or it also could be due to like periods and things in women. Other common causes, especially in other parts of the world, so thalassemia and sickle cell disease can be quite common. And then there are sort of more rare things like sort of lead poisoning, sideroblastic anemia. Then for those normocytic anemias, just think again, what can happen quite acutely. So the acute blood loss, and then again, anemia of chronic disease. And that would just be due to something underlying, something like rheumatoid arthritis, something like Crohn's disease, anything autoimmune that can all cause normocytic anemia. Sort of, again, slightly rare things, hemolytic anemia, hypothyroidism, aplastic anemia, where the bone marrow is actually not producing blood cells. Those could all be due to underlying things like malignancy. Then we're thinking about the macrocytic causes. So those are big blood cells, and very commonly due to B12 or folate deficiency. Not that, the blood cells aren't able to make DNA. Then other things that can cause macrocytic, and these would be non-megaloblastic, would be alcohol, liver disease, hypothyroidism, or certain medications. And also another really common one is pregnancy, and pregnancy really is a common cause of anemia. And then we'll then sort of chat through, if you're asked to take a history from someone who has symptoms of anemia, what symptoms you really need to pinpoint into to elicit that.
Yeah, so some of the key symptoms that you're going to want to try and bring out is your tiredness and fatigue, which is the most obvious one. Other things like shortness of breath and exertion because of that low oxygen, palpitations because the heart's trying to work a bit harder because of the low oxygen. Other things that they can have is feeling dizzy, having headaches. Something else that normally comes in your examination, pale skin or conjunctiva, but you can sometimes ask that in your history. Has anybody said that you've been looking pale or anything recently?
So those are key symptoms to go through. Then we're just going to use the exact same framework we've been talking about, is the OPERA framework. When did the tiredness start? And I think probably for anemia, especially at a first or second year level, they're going to be a patient who is tired all the time. So when did the tiredness start? Was it gradual or sudden? Is it progressing? Is it getting any better, worse, or staying the same? Often it's pretty much just constant all the time, not relieved by sleep or anything. So is there anything that actually does make it worse? And often that'll just be activities of daily living, going out to the shops, walking about. And then we have to think about sort of, again, those related symptoms. And Peter covered a good few of those there. And that'll be things like, are they having palpitations because of their anemia? And I would say that would be only with more significant anemia. And that could be a worrying sign. Commonly things like, as Peter was saying about, fainting and headaches. But again, it can be quite non-specific, and it can also then become more difficult when you're trying to sort of exclude other diagnoses. And it's good to think of differentials like hypothyroidism and things which can overlap a lot with that tiredness. And when you're taking the anemia history, one of the important things in your mind is to think of what is the underlying cause of this, once you suspect it to be anemia. And that will actually allow you to tailor a lot of your questions just using sort of common sense. So are we thinking that the common cause is due to like blood loss? So is there blood coming out either the top end or the tail end? So that could be things like coughing up blood, and that could be due to like a lung malignancy. Are they vomiting up blood because there's a stomach ulcer? Again, some problem with the stomach. Again, malignancy is a big one. And then are they passing blood down the other end? And is there lots of blood in the stool that's making them anemic? Other common things, The menstrual history will be really, really important, especially for patients with heavy periods, and then also postmenopausal bleeding. And again, we're thinking about maybe endometrial malignancy, and it's just having an idea of that. Other things, is it their diet that's actually causing the anemia? So is there nutritional difficulties? And that'll be things like, are they on a vegetarian or vegan diet? What's their alcohol like? Then we need to think about chronic illnesses. So do they have symptoms of things like inflammatory bowel disease, celiac? So is there bloating, diarrhea, weight loss? Is there something else going on? As we mentioned earlier, it can be caused by things like arthritis, ankylosing spondylitis, anything autoimmune. So just again, you'll pick that up in your sort of quick systems review that you go over. And the quick systems review is really important so that you don't miss red flag symptoms. And, a number of the symptoms that we were talking about there are red flag. If someone's coughing up blood, that's very red flag. If they're having vaginal bleeding, they're postmenopausal, that's a red flag symptom. If they're losing weight alongside all this, or there's any of what we call the B symptoms, and that would be things like fever, fatigue, weight loss, or night sweats, and that could all be, you'd be thinking more about a hematological malignancy, something like leukemia. So it's important that you do that just in your systems review. Moving on to sort of the past medical history and the medications they might be on. Do they have any known chronic disease? And again, you just use your open questions. And then things that can make people bleed. So the big one there would be things like anticoagulants. And I think especially, so just saying, are you on blood thinners at the moment? Or are you taking lots of ibuprofen or aspirin? And those are things that people commonly take and don't realize can actually cause bleeding. Then thinking more into sort of the social history, we were talking about sort of diet and alcohol, the smoking, or even, there's a bit more sort of niche, but is there any travel history or any family history of things like sickle cell anemia or people having to come into hospital with anemia?
OSCE Talk tip. This will be the first time as a first-year medical student you might be asking some sensitive questions. Women's health is not something that you will cover until later years, but it's important to be sensitive around this issue. If you get from the start of your history that's a 75-year-old female, you maybe want to phrase it, are you experiencing any bleeding from down below? If it's a younger patient, just broaching the topic sensitively. Is it okay if I ask about your periods? Then when they answer that, are your periods heavy? How many pads are you using and things like that? But you might see that from our history that we do later on.
Completely. And so then we have to work this up in GP. And there's a number of ways that we can do that. So obviously the basics will be doing a thorough physical exam, doing a cardiovascular and possibly a respiratory exam, and then a focused examination depending on what the patient's presenting with. We will then also do sort of a set of routine bloods, and that's normally known as the tiredness panel. That will include things like a full blood count just to look at the blood cells and how many of them there are. But then, if we want to look at that in more detail, things like the size of the blood cells, the MCV that we were talking about earlier, that's actually a separate test, and that's called the iron profile. Sometimes one is done before the other, or often, they're just done at the exact same time. We also need to think about a UNE. Is there issues with chronic kidney disease causing anemia? We'll look at the B12 and folate. Earlier we were talking about sort of megaloblastic anemia. Then things like thyroid function that can actually mimic anemia or cause anemia in itself. Then we'll sort of think about very specific and tailored tests. Does the patient have blood in the stool? Do they need a what's known as a Q-fit test, a test for blood in the stool? And again, that's thinking sort of about colorectal malignancy. Are they coughing up blood and do they need chest x-ray? It is just really tailoring the investigations that you do to the patient. There are also sort of very more complicated ones that hematology may do. That could be things like a blood smear or a hemolysis screen. But again, I think at that point you're sort of referring in hematology. Obviously, just to also mention that if you pick up on any red flag symptoms, if you are getting the B symptoms of fever, fatigue, weight loss, night sweats, if you're picking up on those, then obviously a referral to hematology, a red flag referral to hematology would be appropriate. Then sort of general management, most patients will have iron deficiency anemia, so I think it's important that we just cover how to manage that. And often in the community, that's just treating the cause. So if it's a patient with heavy periods, do they need to use some form of contraception? Do they maybe need tranexamic acid to reduce the amount of bleeding? Other things then we might need to do is actually replace the iron. So are they getting enough iron in their diet and giving them dietary advice, cutting down on things like tannins in tea, which actually reduce iron absorption, and then making sure they're having enough vitamin C as well, because that's actually important with iron absorption. But then we might need to give it to them in a tablet form. So often this will be in the form of ferrous fumarate or ferrous sulfate, and those are normally tablets just taken throughout the day. Just quickly to mention that patients find them quite unpleasant. They can have quite a strong metallic taste, and they can actually cause, constipation and dark stools, which can be slightly worrying for the patients. Sort of more advanced than that, some patients might need IV iron. Obviously, anything going straight into the bloodstream is slightly higher risk, and especially for a blood reaction, and especially with IV iron, there's actually a risk of bacterial infection because of the temperature that it's stored at. And iron is a good source of bacterial growth as well. And so IV iron is actually slightly higher risk. And then finally, some patients will progress onto the need for needing a blood transfusion. Blood transfusions are basically only done in hospital or in sort of specific clinics for them. There are patients who are on long-term transfusions, but obviously transfusions carry their own risk, whether that is allergy, getting the wrong type of blood, or just even simple reactions like getting a temperature, and that's something that needs really closely monitored. So obviously that's not being offered to anyone, and usually there's a threshold trigger for people who need transfusion. So that will be usually 70 in most healthy adults under 65, and they'll have if their hemoglobin drops below 70, then they may need to have a transfusion. There might be a slightly higher threshold depending on comorbidities, and normally that's about 80. And the aim is usually to bring it up by about 10. And that shows that they've had a response to the transfusion. And that's sort of how you would work through the management, basically.
Yes, brilliant, Matthew. Thank you for taking us through all of that. We're going to move in now to our example history. We're going to focus more on a female patient here because I think that's going to be useful because it's not something that you maybe have done before. We will cover the more typical sort of rectal bleeding patients in later histories with more red flag anemia type symptoms.
Okay, so hello, my name is Matthew Pettigrew. I'm one of the resident doctors in GP today. Do you mind if I check your full name and age, please?
Hi, yeah, I'll be Patricia. I'm a 19-year-old female.
Patricia, and do you mind telling me a bit about why you've come into GP today?
Yeah, I've just been feeling very tired.
And Patricia, how long has that tiredness been going on for?
Oh, I'd say 3 or 4 months.
And over the last 3 or 4 months, has that sort of changed at all? Is it getting any better, any worse?
Slowly worse.
Is there anything you can think that could have caused that in the last few months?
Honestly, not sure.
And is there anything that makes that worse sort of day to day?
No, like when I sleep, it makes it a wee bit better, but like very soon after, I feel just as bad.
And do you get any relief from sleep?
Not really.
Is it impacting your ability to do things sort of day to day?
Yeah, so I'm currently in university and like I've just can hardly stay awake in my lectures.
And have you noticed any other symptoms that sort of you want to mention?
Just feeling a bit like breathless, almost, but faint at times.
And what would make you feel breathless?
If I was like going out for a brisk walk at the moment, I'd feel breathless.
Okay. And can you exercise at all at the moment?
I think I'd struggle.
And would you have been able to do that before the last few months?
Yeah, I would, yeah.
And are you breathless at any other points during the day, such as nighttime?
No.
Do you have any sort of problems with the chest? Any pains in the chest at all?
No.
Any problems with feeling the heart beating very quickly?
No.
Do you feel like you're getting lightheaded or ever passing out at all?
Yeah, I've been feeling a bit lightheaded when I'm at uni and like if I had to stand up for a period of time.
And has that ever caused you to lose consciousness or pass out?
No, I haven't.
And you've mentioned sort of the sleeping. Is there any change to your sleep?
No, well, I'm sleeping more.
Are you waking up in the middle of the night or anything?
No.
And any sweating at night or anything?
No.
Any change to your weight at all?
No.
Any change to how much you're eating?
Probably like since I went to university, like I've been cooking for myself and stuff and, probably not having a great diet.
And what would you say sort of diet you follow?
I've been eating a lot of like pasta and toast and stuff like that.
Okay. And do you eat any red meat or anything at the moment?
Not really.
Have you noticed any sort of, funny marks on the skin or changes of the skin?
No.
Looking more pale or anything like that?
I think I'm a bit paler. Yeah.
Have you noticed that you're losing blood from anywhere, such as coughing up any blood?
No.
Any sort of new nosebleeds?
No.
Sort of passing stool with blood in it?
No.
Or any change to the periods at all?
Well, they've always been a bit heavy.
And can you tell me sort of what your normal cycle length would be?
It's usually like just regular 28 days.
When you have bleeding, how many period products would you use sort of within your period?
I use quite a lot. I use pads. It could be 8 or 9 pads a day.
And would you ever bleed through pads?
I have before, yeah.
And can I ask, are you passing many clots or anything like that?
I am, but like they're small.
And have you had any change in the periods recently and specifically in the last few months?
I think it's got worse, really in the last 6 to 7 months, yeah.
Sorry to hear that. Any sort of pain down below?
No.
Any sort of bloating of the tummy?
No.
Any new discharge down below?
No.
And can I ask, are you sexually active at the moment?
I'm not.
Sort of what sort of impact is this having on you at the moment?
I'm actually quite stressed just with uni and like missing lectures and I just feel like I can't cope.
And any worries that you're having at the minute?
Not really, just apart from being tired.
And what would you like out of today?
I just don't want to be as tired. Like I want to pass my exams and do well.
Completely. Are you living with any medical conditions at the moment, Patricia?
No.
Do you have any history of anemia?
No.
Does anyone in your family have any problems with sort of anemia or anything like that?
No, I don't think so.
Any recent injuries or anything like that? Or surgeries?
No.
Do you take any regular medications?
No.
Anything that would thin the blood at all?
No.
Would you ever take sort of ibuprofen or paracetamol or anything?
I would take Brufen from time to time, but...
Any herbal medications? Any allergies at all?
No.
And can you tell me a bit about how things are sort of at home? You said you're a university student at the moment. How are you finding that?
I'm enjoying university. It's just honestly being tired and just feeling like I'm missing out on lectures because I just feel so tired.
And are you working at the moment at all?
I'm not.
Do you smoke at the moment?
I don't know.
And do you drink any alcohol?
I would drink socially maybe once a week.
And this is one of the questions that we have to ask, but have you ever used sort of any illegal or recreational drugs or anything?
No.
Patricia, that's all the questions I have for you today. Anything that you want to mention or anything you feel like I've missed out on?
No, I don't think so.
Thanks very much for talking to me.
Thank you. Yeah, brilliant, Matthew. I thought that was well done. I just thought I'd break down some of the social issues you went through. I thought that was really good. This person with the sort of bad diet, really common, and actually this could go the other way, and it could be, you know, a 60-year-old man who's at the home and having the similar diet, sort of tea and toast diet and things like that. So really well done. And again, just bringing out alcohol, smoking, it's really important for these types of histories as well. Impact in daily life is really important, particularly in this person who seems to be struggling at university. And so, no, well done. So thanks for listening, everyone. I think that'll finish us up for this episode.